expiratory volume, because essentially expiratory volume tells you what went into the lung. The problem with ET leak is if you've got a large leak, you can also get leak during expiration, and so your measured tidal volumes start to become inaccurate. And most ventilators can cope with a leak up to about 50%, but once the leak gets beyond 50%, you really have no idea what tidal volumes are being delivered. And I guess you've got a couple of options if you're in that situation. One, if the baby's close to extubation, you can just take the tube out and put the baby on the CPAP, and that fixes your problem. The next option is changing to a larger endotracheal tube. Now, there's some problems with that. First of all, it can be a bit scary to take a tube out and put a new one in a baby who's a little bit unstable. And also you worry that if you put in too big a tube, they're going to cause injury to the upper airway. However, in my experience, if you've got a really large leak and it's really affecting the baby's stability, I think and the baby isn't able to be extubated soon, I think there is big advantage in changing the ET tube to the next size up. The other thing people do is they remove the volume guarantee function and just go back to a set pressure. The disadvantage of that is that you've got no idea what tidal volumes you're delivering. They can be high, they can be low, they can constantly change. And so you've lost all the benefits of volume guarantee. Then there's the issue of trigger sensitivity. So the way trigger sensitivity works is when you get flow over the sensor at a very low threshold, only small amounts of gas movement are sufficient to trigger the ventilator to take a breath. At high trigger sensitivities, at high levels, you need a large amount of gas. So what you want to do is you want to set your trigger sensitivity so that you get the minimum amount of stimulus to trigger inspiration. Because if you have the trigger sensitivity set wrong, the baby actually has to take a significant breath before the ventilator triggers. So your synchronicity between the baby taking a breath and then the ventilator firing is delayed, and that actually increases the work of breathing. The problem with trigger sensitivity is you can get what we call auto-triggering. So auto-triggering is when the ventilator thinks the baby's taking a breath, but it's really not. And one of the more common reasons for that is you get water build up in the circuit, and you'll see the water sort of bubbling in the circuit, and that can be enough to trigger the ventilator, and auto-triggering occurs. Now, auto-triggering, it's very problematic because you'll get asked to see a baby who's got a respiratory rate of 80, 90, 100. What's wrong with this baby? In fact, there's nothing wrong with the baby. The problem is the ventilator. And one of the clues to picking auto-triggering is each breath is almost precisely the same as the one before. And we know that when you watch babies breathe, their respiratory rates go up a bit, down a bit. So the gap between each breath varies a little bit more, sometimes less sometimes. So when you see a ventilator that is firing at a very fast rate and each one is just almost precisely the same rate, then you think of auto-triggering. And the way you manage auto-triggering is, first of all, you empty the water out of the circuit, and you can see the difference the water being emptied out of the circuit makes to the flow pattern. If that still doesn't fix the auto triggering, you then have to change the flow sensor, because it probably means the flow sensor is dirty or wet. So let's look at just some troubleshooting with problems related to ventilators and babies. So one of the scenarios you can see is a baby has a high respiratory rate and low oxygen saturations. The other problem we can see is that the baby persistently has, on volume guarantee, only very low pressure each time the ventilator fires, but their blood gases aren't good. So there are a couple of likely causes here. One is that you've got too low a FRC, and the baby's total lung volume is low. So you perhaps need to increase the P. The other problem is there's a pressure support mode called PSV. I don't know if you use PSV, but PSV is a little bit different to normal triggering. So with normal triggering, what happens is when the ventilator senses that the baby's taking a breath, you get the pressure rise, and it's held at that pressure for the set inspiratory time. So the inspiratory time doesn't change. With PSV, it's a little bit different. So what PSV does is it looks at the flow. The flow rises, and then as the lungs start to fall, it starts to decrease. When it gets down to about 15% of the maximum flow, the ventilator decides that there's been enough filling of the lungs, and it cuts short the inspiratory time. Now, PSV is a really good strategy in some situations, but particularly in the very premature baby, what it can do is, because you're using such small tidal volumes, is that it cannot be sensing truly what's going on, and you end up with very short inspiratory times, which means every time the baby takes a breath, they never get adequate lung filling, so they tend to collapse their lungs down. So for a while, one of our neonatologists thought that PSV was the best form of support, because the babies do look more comfortable on it. But what would usually happen is they'd be okay for maybe a day or so, and then they just collapse down and get into all sorts of trouble. The most common problem is that you just set your tidal volume too low. So babies aren't stupid. They sense, just like you and I, if you restrict us from breathing normally, we feel really uncomfortable and we try to do something about it. Same with the baby. If you're restricting their tidal volume each breath, they feel underventilated. And the way they respond to that is they breathe faster, or they actually put in a lot of effort to overcome the ventilator. So they're doing all the work of breathing, and the ventilator's requiring minimal pressure to support the breaths. And the last reason for seeing this sort of situation is when you've got a very large leak, and the ventilator thinks that it's delivering 5 mils per kilo, but it's not. So I thought we'd just have a quick look at some of these things again. So this is the inspiratory, expiratory time, which we've talked about. These are actually very helpful loops, particularly babies with unusual lung conditions like evolving chronic lung disease. So this is a flow volume loop, and on most ventilators you can bring this up. And so the flow volume loop goes in a clockwise direction During inspiration, you get maximum in the spiritual flow, drops back down to 0, then you get expiration in the opposite direction. So there are certain circumstances where this gives you a lot of information. So in your normal flow volume loop, you always come back to 0. If you have a flow volume loop that doesn't come back to 0, there's no return to baseline. What that means is that some of the volume of gas has stayed trapped in the lungs, in the gas trapping. The other loop that's really helpful is the volume pressure loop. And there's 2 parts to this. So with good compliance, the volume pressure loop has a slope of about 45 degrees. With poor compliance, it sits down much flatter. So you can get an idea of whether the surfactant's been helpful. But one of the things that's really useful on this is it gives you a clue to whether you're over distending. So with normal lung volumes, you just have this tiny little beak here. But when the lungs are overinflated, what you see is a big area of beaking. So when I'm trying to work out whether the pressures are too high, whether the peak's too high, I look at this loop and it gives me a clue. And what I do is I just bring the peak back a little bit, until I get that appearance. And I feel like I've had a better chance at sort of individualising the baby's ventilation. I guess, so we've talked about ventilation, but what happens next? And our goal is to get the baby off the ventilator as soon as possible, because being on a ventilator is associated with a number of problems. You can get ventilator-induced pneumonia, pneumothorax, PLAE, and chronic lung disease. And basically, each additional week that a baby spends on a ventilator significantly increases the risk of them having long-term neurodevelopmental problems. So generally speaking, as soon as we get a small baby intubated, we should be starting to think about preparing this baby to be extubated. That doesn't mean that we can extubate all babies in 1 or 2 days, but what it means is we should be always thinking about when can we do this, how can we maximise the chances of doing this. So it's important to be proactive in the weaning process. You can get trapped into this baby is fine, this baby is stable, everything is good, we'll just keep doing the same thing day after day after day because nothing's going wrong. But in fact, if we want to reduce the risks of long-term ventilation, we should be aiming for the minimum amount of time on the ventilator. Planned extubation is actually a complex process. So first of all, it involves active weaning of your ventilation settings. Then it involves evaluating whether the baby is actually ready to extubate. And then finally, you have to think about what's the best way to support the baby after the baby's been extubated. There's 3 main problems. One is that everybody does things differently. In a lot of units, there's no common strategy towards weaning ventilation. So in extremely little babies, most of us use SIPPV. And that's because you've got a small ET tube, a small baby, mechanically inefficient. If you ask them to support their own breath for any time, it's increased work breathing, they get tired, they start to collapse down. So you can't, years ago, we used to wean ventilation by progressively reducing the rate until we got to a low rate and would extubate the baby. And by the time we got the baby to a low rate and extubated them, they were absolutely exhausted and they failed. And then we realised the best thing to do was to keep them on a good rate. And that's why we use SIPPV. So the only thing that you can actually wean is tidal volume in reality, tidal volume in oxygen. But again, you don't keep weaning the tidal volume. I always set a limit of 4 mils per kilo. So that's my strategy. Different people have different ways of doing it, but that's my strategy. Once I get to 4 mils per kilo and a reasonable oxygen level, then I start asking myself, will this baby be able to be extubated? We have to be conscious that about up to 50% of babies, when the first time we extubate them, fail, and we don't want that. So extubation failure is a significant clinical problem. So extubation failure is independently associated with increased risks of mortality, increased length of stay in hospital, increased days in oxygen, and increased days on ventilator support. And that kind of makes sense because you extubate these babies, they fail, and by the time you re-intubate them, their lung disease, they collapse their lungs down, then you need a whole lot of effort to re-expand them, a whole lot more oxygen, and it takes them days and days to recover. So it's really important that when we choose to extubate a baby, we're confident that this is the best they can be. Problem is there's very limited data for the clinician to work out optimal ways. So I mentioned before SIMV versus SIPPV. Not many neonatal units use SIMV in very low birth weight, extremely low birth weight babies. And I mentioned about low tidal volumes. If you reduce the tidal volume too low, in fact, all you're doing is ventilating the dead space, because the tidal volume is actually less than what you need to overcome the dead space. So there are some published criteria. So Martin Kessler, he's a big name in the United States who publishes a lot of stuff to help clinicians make decisions. And on conventional ventilation, he's set out some parameters where he feels that if you get close to these parameters, you're most likely to succeed. So on assist control, baby less than 1,000 grams, you're looking for a median weight pressure of somewhere around 7 and an oxygen of somewhere around less than 30%. That's the ideal situation. The problem is sometimes we just can't get there. So we have to choose whether or not we're going to extubate the baby. With volume targeted ventilation, as I mentioned, tidal volume of 4 mils per kilo and less than about 30% oxygen. Extubation failure, let's look at the risks of extubation failure. Well, of course, the smaller you are, the bigger the risk. History of previous extubation. Have to be conscious of sedatives. So one of the things in my mind that's really important is when you're planning to extubate the baby, if the baby's on sedation, you turn it off sufficiently long before you extubate the baby so the baby's not sedated when you extubate them. We want to avoid multiple reintubations. One big thing that's in my mind important is a hemodynamically significant duct. So when I'm assessing a very small baby for are they ready to extubate, one of the things I make sure is they haven't got a big duct. And I would plan to treat that duct before I tried to ventilate the baby. And the main reason for that is I've had experience where people who have extubated babies who've got hemodynamically significant ducts on the basis that the baby's needing minimal ventilation and it's seemingly doing fine and the duct's not important. And then after about 2 or 3 hours, the baby has a massive pulmonary hemorrhage. So I think it's really important in your extubation planning to rule out the PVA. The flip side of extubating a baby is when you get to extubation criteria, should you extubate them straight away or should you give them a little bit more time and just give them a bit more time to get bigger, stronger? Basically, what the group did a study where they had set criteria for extubation and they randomised them to either, as soon as they got to those criteria, you extubated them, or when you got them to those criteria, you waited a couple of days and then extubated them. And they found that delaying extubation once you hit the criteria didn't have any real effect on extubation failure. So most people, I guess what we do is when we are confident we've reached our extubation criteria, we just seize the moment and do it rather than put it off for another day. Predictors of extubation readiness. There's a little bit of controversy here. Some people believe in spontaneous breathing trials, some people don't. So a group in Melbourne, what they did was they designed a protocol where when they thought the baby was ready for extubation, they gave the baby a 3-minute ET-CPAP trial. And in that time, what they said was that if they accepted up to a 15% increase in oxygen, but that the heart rate had to stay above 100 during that time. And what they found was that if the baby passed the CPAP trial, it had a very high positive predictive value for extubation success. So in that unit, they've adopted that as a standard of care. Other units don't, and there are certainly a lot of people who disagree with it. I find myself a spontaneous breathing trial very useful because I've identified that there are babies that absolutely look fantastic on the ventilator. They're triggering the ventilator consistently. You give them a 3-minute trial of spontaneous breathing, and after about 20 seconds, they just go apneic and bradycardic. Now, if I'd extubated that baby clearly would have failed. I then do the spontaneous breathing trial again later that day. If they don't pass, I do it the next morning, and I just keep doing it until the baby passes and extubatable. And most of the time, the delay is only about 24, maybe 36 hours at the most. But what I find is when the baby passes, the baby survives the immediate extubation time. Salish, he published some recommendations for planning on extubation. Now, one of the things that he identified as important was a multidisciplinary discussion. So when I plan to extubate a baby, the first question I have is for the nurses. Do you think this baby's ready? And the reason why I think that's important information is they're at the bedside all the time. I'm only at the bedside for short periods of time through the day. And so they know the baby much better than me. They know that when they disconnect to suction the baby or when they shift the baby's position, whether the baby really tolerates it well or whether the baby goes bradycardic. So I think the idea of talking to your team about whether we all agree that the baby's ready to go is really, really important. The other thing is that there's no real evidence that, at least in babies over 24 weeks, that you delay extubation just based on weight and gestation. I think there's some evidence that the 22, 23 week is maybe a bit different, but for most of our babies, if they're ready, they're ready. Strategies that help with weaning is optimising nutrition, optimising caffeine dosing, considering postnatal steroids. So the European Consensus Guidelines most recently published said that any baby who's been on ventilator for longer than 1 week, who is not showing any signs that they're likely to come off the ventilator soon, should be considered for postnatal steroids for extubation. And that's because there's a lot of evidence that you get the most benefit from postnatal steroids if you use them relatively early, rather than waiting 5, 6 or 7 weeks and then thinking, oh, I've got to do something now. Because it makes sense, the ventilator-induced lung disease has only got worse, and it's largely the ventilator-induced lung disease that you're trying to overcome. Then they set down some parameters, so mean airway pressure between 6 to 8, oxygen between 21 and 30%. If you're using pressure control, pressures between 12 and 15, with tidal volumes it's about 4, and a good pH. And then they suggest in their guidelines they didn't believe there was sufficient evidence to support spontaneous breathing trials. My personal experience is different. Okay, so any questions?
Hỏi em. One question in fellowship. Sometimes we have baby with a long day of ventilation. When we extubation, this baby actually unplanned extubation. The baby have beep 6 to 7, and the FiO2 over 70%.
Yep.
The baby have extremely intercostal rejection.
Yep.
But the blood gas is normal.
Yes.
Should we intubation or continue to NIV?
Right. Okay, so there's some interesting things about nasal positive pressure ventilation, and we need to think about nasal positive pressure ventilation depending upon what equipment you've got. So some ventilators can do synchronized nasal positive pressure ventilation, and in that situation there's clear evidence that the positive pressure breaths delivered into the nasal prongs do actually ventilate the lungs. So they do improve CO2 exchange. They do help support breathing. Then, like most of us, we have ventilators that can't synchronize nasal positive pressure ventilation. So it just delivers a breath whenever it feels like it, and the baby may be taking the breath, the baby may not be taking the breath. The way people think that works is that there's a reflex called Head's reflex. And when you stretch up the upper airway, you have a reflex that drives the baby to take a breath. So a lot of people think that the main benefit from unsynchronized nasal positive pressure ventilation is just triggering the baby to have a breath. So you're actually mainly focusing on apnea, but it doesn't really contribute in any way to the ventilation. So if I have a baby who has a high oxygen requirement and increased work of breathing on CPAP, would I consider nasal positive pressure ventilation? Without synchronisation, that wouldn't be my first step. And the reason for that is that I know that it's probably not going to improve gas exchange in the baby. So when I look at what your problems are, high oxygen requirement, work breathing, what that tells me is that you've got lung collapse, you've got VQ mismatch, and because you're working at lower lung volumes, when you look at that sort of static compliance loop, you know when you're at low lung volumes you need a lot more work to generate the tidal volume. So my response to that scenario would be to increase the peak. And I'd increase the peak, the best way you could do it would be just to go up step by step by step until you see benefit from it. The benefit won't be immediate though, it takes a while to recruit. So if I had a baby on say a peak of 6 who was had problems with oxygen and work breathing, I would probably immediately go to 8 and watch the baby for an hour or 2. If they were showing some signs of improvement, I'd give them more time. If after an hour or 2 they were really no better than they were on 8, I would then probably go to 10. Because what I know is that it's going to take a lot of effort to re-recruit the baby. Once I've re-recruited the baby, the oxygen requirement comes down, the work breathing comes down. The next question is, do I really need that higher pressure, or can I come down a bit? So what I might do if I was on a CPAP of 10, particularly if the baby's belly was getting a bit distended, I might bring it down to 9 and see how the baby copes with that. Because once you've sort of inflated the lungs, you perhaps don't need so much pressure to keep them. But my response to that scenario would not be an IPPV, because I don't think it's addressing the primary problem. The primary problem is low lung volume, and unsynchronized NIPPV, from all the evidence I've seen, does not actually improve gas volume exchange. So we use NIPPV primarily in babies who are worried about apnea. So we will, with our very little babies, when we first extubate them, we will often start them on NIPPV just to make sure that we're reducing the risk of them having apnea. And then if they prove that they're very stable, they've got good respiratory drive, then we might slowly reduce the NIPPV and take it off. Because we believe most of the benefit actually comes from the actual distending pressure rather than the NIPPV. Now, when I visited Europe last year, they were using NAVA technology, and they were saying that NAVA technology definitely improves the ventilation. So if you did have NAVA technology and you had a baby like that, you might go straight to NIPPV to see if you could improve the ventilation. But at the moment, I think that's, because it's expensive, I think that's out of reach for most of us. And it's only in Europe where it seems to be more commonly used. NAVA is very big.
Thank you. Hỏi nhau mọi người. Our extremely preterm baby. Sometimes we use the BIP under 11 with FiO2 under 30%.
Yeah.
But the thất bại đấy. But the failure of extubation is really high.
Yeah.
So
I guess I'm always a little bit cautious about. I guess it depends on whether the tidal volumes are still 4 mils per kilo or more. I'm always cautious with the very little babies is as you're planning to extubate them, you don't want to allow them to lose lung volume and start to collapse down at areas of the lung. So, as I mentioned before, the preterm lung is a little bit different. At normal lung volume, it's still very close to what I call closing volume. So what I mean by closing volume is during exhalation, if the lung volumes drop enough, the airways start to collapse, and then you get into this problem of little patches of atelectasis in the lungs. So if you allow the lung volumes to drop too much before you extubate the baby, you can be extubating the baby at a time when they've actually already starting to develop some atelectasis. So pressure, I'm not so worried about. So if the baby were generating good tidal volumes on 11 mils per kilo, I would think that were really good. But if I were, pressures of 11 centimetres of water, but if my aim was to get the baby to 11 centimetres of water, but the tidal volumes were getting low, then I would prefer to have higher pressures, keep the tidal volumes higher, so that I'm extubating the baby at a time when the lungs are well recruited. And that was something we learnt from weaning on SIMV. When we weaned babies on SIMV, they would just progressively collapse down. And by the time we extubated them, they already had significant atelectasis. And a lot of them would just very quickly fail. And then you'd have to re-recruit them. And then, as one of the neonatologists that I knew said to me, said, why would you even do that? Why don't you just extubate the baby while they're good, rather than extubating them when you've allowed them to collapse down?
And what is the successful rate of extubation in your hospital in early, extremely preterm baby?
So there's the typical discussion we would have on our ward round when we get to an extremely low birth weight baby who's now 3 or 4 days old is this baby ready to extubate? So I go through a little bit of a checklist. First of all, what is the hemoglobin? Does the baby need a transfusion? Because if the baby needs a transfusion, we should transfuse them before we extubate them. What is the duct doing? Is the duct constricting? Is the duct closed, or is it big and open? If it's big and open, let's treat it before we think about extubating. Is there any signs of infection? If we've treated all the infection and the CRPs are normal and the baby's clinically really good, that's great. Then I look at the ventilation. So how do I decide? First of all, I like to have the oxygen requirement under 30%. Closer to 25% is even better, but I accept 30%. Usually when you extubate, the oxygen requirement drops a little bit, but as long as I feel like it's likely to stay below 40%, I'm comfortable on CPAP. Then I look at what sort of pressures I'm needing to generate my set tidal volumes of 4 mils per kilo. And I guess I'm looking for pressures probably 15 to 18 or less. I would be hesitant in the first 4 or 5 days of life if the baby were needing 20 or more pressures, because I would sort of think that the baby's going to struggle to be able to provide that sort of effort with their breathing. And then I do my CPAP test, and if the baby passes the CPAP test, then what we do is we talk to the nursing staff and say, okay, we're going to extubate this baby. Are there any procedures that we need to do first? So if the IV needs changing, if we're going to put in a percutaneous central line, the last thing you want to do is to extubate the baby and then 3 or 4 hours handle the baby to do a procedure. So I make sure that any procedures that need to be done, even things like weighing the baby and stuff like that, we get all that done first. So that once we're ready to extubate the baby, we can extubate the baby and then stand back and do nothing for 4 to 6 hours. Just not handle the baby, leave the baby alone. The optimal position, I think, for extubating the baby is lying on their front. And the reason for that is that when they're laying on their front, it stabilises the abdominal wall, and that actually makes the diaphragm movement more efficient. So keeping them prone is good. And that's really important because babies are mostly diaphragm breathers. The intercostal muscles are not very good and they really contribute very little at all. So optimising diaphragm movement. We tend to, before we extubate babies, we tend to stop their feed, empty their stomach. Some people like to keep them fasting for 4 hours afterwards in case the baby fails, but I don't think that that's important. I think usually you can tell within an hour that the baby's going to do okay or the baby's in trouble. And I like to get the feeds going back again as quickly as possible. So those are the kind of things. The other thing is just making sure that the caffeine dose is appropriate. Sometimes the caffeine dose has been written up and it's not at the top level, but I'll make sure that the caffeine level is right up there. So that's sort of like the sequence of events. So usually when we're talking about planning, our discussion is probably a good 10 minutes of us. We just go through everything and make sure that it's okay. The other thing that I'm a big fan of is when I extubate a baby, I actually prefer to extubate them in the morning so that if something goes wrong, I'm there. I prefer not to extubate the baby late in the afternoon or early evening because night shift can be very busy and that's when things get missed. Nobody's watching the baby closely, nobody's adjusting the CPAP properly. So I try to plan to extubate a baby when I know that they can be watched very closely, at least for the next 3 or 4 hours, to make sure that they're doing well. And the other thing that I guess comes into it is often parents want to be there when we extubate the baby, so that sort of sometimes influences the time a little bit.
The baby generally 24 weeks should be intubated or not after birth?
Okay, so that's a good question. I think we shouldn't intubate the baby unless there are clear reasons to do it. So it's quite possible that the baby will end up being intubated, but it's also, we have had 24-weekers who've gone through the first week of life without needing to be intubated. So my strategy for a 24-weeker would be to resuscitate, support them, and if they haven't got really terrible work of breathing, if they're not needing really high oxygen, is to get them onto CPAP as quickly as possible. And then what I do is I watch them for about 5 or 10 minutes. If I feel that they're stable and comfortable, then I will move them to the nursery on CPAP. Then the next question is, if the baby does increase their oxygen or their work of breathing, do you intubate them and give them surfactant, or do you do mist? I've been in the 24-weeker, I've been very disappointed in missed. We missed a number of 24-weekers and almost all of them end up being intubated. So at 24 weeks, if I were going to give surfactant, I think I would just intubate the baby, give surfactant, stabilise the baby over a day or two, and then re-intubate. At 25 weeks and above, I'm more inclined to do misting, and certainly at 27, 28 weeks. If I didn't have any immediate reason to ventilate the baby, my first option would be to do mist and give surfactant that way. The bigger babies tend to do quite well with mist. My experience with the smaller babies is they don't necessarily tolerate the misting very well, and within an hour or two you're making a decision to intubate them anyhow. And I think it just spares them the stress of going through mist and then having to be intubated.
You think generally 24 or 25 weeks? How long ventilator for the baby? Intubate.
Right. So you routinely intubate at 24, 25?
How long?
Oh, how long?
Ventilator.
That depends on the baby. Look, typically at 24, 25 weeks, we wouldn't get them off in the first 24, 48 hours. I think it takes just that length of time to be comfortable that their duct is good. One of the things that I'm very conscious of is intracranial hemorrhage. So if I have a baby 24, 25 weeks on a ventilator, who I consider to be a relatively high risk of intracranial hemorrhage, I want to keep that baby as stable as possible for the first 72 hours. So what I do is I use that 72 hours to get the baby stable, to make my decisions about the duct, etc. But even if at 48 hours the baby looks like they could be extubated, I would keep them on the ventilator for another 24 hours. Because what I'm worried about is if I extubate the baby and it's unsuccessful, the stress of re-intubating, the stress of failure may be enough to trigger an IVH. And that's really important to me because I can't fix that. If I keep the baby on the ventilator for a day or two longer, it's very unlikely to cause problems that I can't fix. So yeah, I agree, the 24, 25 weeker is a bit different.
Sorry, I have a question about steroid.
Yes.
When do you use and how much dose do you use? And if you maybe extubation failure, do you repeat? And how many days do you repeat steroid for baby? So
if we're talking about postnatal steroids to get the baby off the ventilator,
yeah.
So I'm a big follower of the European consensus guidelines because they're a group of people that looked at all the evidence, and so I think that they're really good guidelines. So I start to think about postnatal steroids after a week. So after 1 week, and it depends a little bit. So some babies at 1 week, their problems are starting to go away, and you think within a few days you could extubate. So I wouldn't give that baby steroids. But once we get to about a week, I then start asking myself, what can I do to help get this baby off the ventilator? Is it because I need to do better with my ventilation? Is it because there's a duct? I better go looking for a duct. Is it because the baby needs transfusion? Is it because there are other problems like maybe some infection developing? So I look at all the things that I can fix, which usually takes me a few days. I also use that time to talk to the parents about using postnatal steroids, because a lot of parents now read the internet, and when they realise their baby's getting postnatal steroids, if they're reading the wrong stuff, it can be very scary about, the harm you can be doing. So usually we're probably midway through into the second week by the time I'm actually at the point where I would use steroids. And so again, I look at the baby and go, there's no chance I'm getting this baby off in the next day or two. Let's do it. There's no advantage in waiting longer. In our nursery, there are two different thoughts. One group likes hydrocortisone. So the alleged benefit of hydrocortisone is that hydrocortisone in experimental models doesn't have a severe effect on the brain as dexamethasone. So hydrocortisone stimulates a receptor that can aggravate apoptosis in the brain, but it also stimulates a receptor that is protective against apoptosis. So people say that's an advantage, because dexamethasone only stimulates the receptor that triggers apoptosis. The problem with the strategy of hydrocortisone is that it's very clear that dexamethasone is better for getting the baby off the ventilator. I've sort of looked at our experience with hydrocortisone, and what tends to happen is most of the babies we treat with hydrocortisone don't respond properly and end up with dexamethasone. So you've exposed them to 2 lots of steroids. There are a small number of babies who do respond really well to hydrocortisone, but then you wonder whether they would have got better by themselves anyhow, so I'm not sure. So after sort of trying different things over the last few years, my preferred strategy is to, when I decide I use steroids, I use the DART protocol, which is low dose. I think it takes 5 days. I can't remember. 7, yeah. So I follow the DART strategy, and I do that because even though the DART trial wasn't fully completed, there's no evidence that dexamethasone in low doses used in the DART protocol actually causes any long-term harm to the brain. Most of the evidence that talked about harmful effects of dexamethasone on the brain were dated back to a time when we were using what we call the Cummins protocol, which is a 42-day dexamethasone course starting at higher doses. And the European Consensus Group also support the use of dexamethasone based on reviewing all the data. So my preferred treatment strategy is probably sometime in the second week of life, if the baby clearly isn't making any progress and there's nothing about them that I can fix other than just waiting for their lungs to magically get better, then I would go straight to the DART protocol. And most of the time, if I treat them early and use DART, the babies come off the ventilator very successfully. The ones that we have the most problem with are the ones where we've waited too long and the baby's lungs are now really bad. And they're the ones that you don't get the dexamethasone response that you want to. So I caution against hoping that the baby will get better, keeping the baby on the ventilator for 4 or 5 weeks, and then starting to think about using dexamethasone, because all the evidence suggests that you're most likely to get the true benefits of dexamethasone earlier. So what's interesting about dexamethasone is, although there were all the concerns about the harmful effects, where it's used like I described it, there is some reduction in incidence of BPD, and there's also some reduction in mortality, and definitely there's a very high success rate in extubation when you start them. So that's my plan at the moment, and it has changed. If you went back 2 or 3 years ago, I probably would have said I'd use hydrocortisone, but I've come to the conclusion that too many babies fail to come off when you start on hydrocortisone, and then you end up going to dexamethasone.
About steroid influence brain baby, do you see? Steroid improve the brain development in the future.
That's a different story. In fact, I think I've got something here that I can refer to. It might help. So this is actually about postnatal steroids, but let's look at early use. So there is some evidence. The Premilock trial, which was done in 2016. So basically this was a trial where they treated the babies straight after birth with 10 days of low dose hydrocortisone. And this is an interesting trial because it showed that early low dose hydrocortisone doesn't increase the chances of neurological problems, but in the 24 to 25 weekers there was actually evidence that it improved overall neurological outcomes. So it was a significant benefit. So the subgroup of 24 to 25 weekers that got the low dose hydrocortisone, their rates of moderate to severe neurological impairment were 2% compared to the group that didn't get hydrocortisone, it was 18%. It's unusual to see benefits that big. And so actually when I was researching the data for talking here, I came across this trial, I thought to myself, when I get home, I need to talk to our group because we need to, I haven't read all the details of this study, but I was thinking I need to go and get this trial out and look at it and start looking at what other evidence there is, because I do know that there are some units in Europe who are now, and I think the Japanese as well, are now offering the very little babies low-dose hydrocortisone in the first week or so of life because they feel that it benefits the baby. So one of the problems, the Japanese talk about adrenal insufficiency. So what they suggest is that most extremely preterm babies have an element of adrenal insufficiency. And it's one of the reasons why they have so many problems in the newborn period. And so if you give low-dose hydrocortisone in the sort of range of physiological replacement rather than anti-inflammatory treatment, then you get benefit from it. And we know that giving early hydrocortisone improves cardiovascular instability, and you wonder whether, at least in part, the benefits of the low-dose hydrocortisone is with greater cardiovascular stability, you're less likely to get a brain injury. So this is, I wouldn't recommend just straight away going to use it, but what I would recommend is looking up this trial and then looking for more data to see whether it's actually worth the consideration. Because, I mean, I've not seen many trials where you get such a significant benefit from a treatment in preventing long-term neurological outcome. 2% versus 18%, that's big. That's really big, and that's very hard to argue against. And one of the things that they did, and it's not important to you, but the one big issue with using hydrocortisone early is it's a risk to use hydrocortisone and indomethacin or ibuprofen early in life. The combination of indomethacin, ibuprofen, with hydrocortisone significantly increases the risk of spontaneous bowel perforation and bowel hemorrhage. But if you use paracetamol as your primary treatment for managing PDAs, then it's not important.
Hỏi gì nữa không? Không là mình nghỉ nhau. Thank you for your presentation. So